It's a great pleasure now to move to one of our featured lectures today by someone who needs no introduction, actually.
Thanks, Dan.
Most of the, well, I'm not finished. No, but from start to finish, we've been hearing about the contributions of Dr. Kapur to the field of unloading, both on the clinical side and really basic side. So his work and his mentorship of so many young people is so prevalent in the field. So thank you for all of that. We owe you a lot of gratitude for all you've done. So with that, Navin is going to talk to us about the molecular mechanisms of unloading and recovery, past, present, and future.
Great, thanks, Dan. And I think it's really important to note that we do truly stand on the shoulder of giants who've come before us, and that's why this talk, I'm going to try to incorporate a little bit of the past and sort of indicate how the past has predicted the future, especially as it relates to molecular mechanisms of unloading and recovery. So one of the areas that I think is really fascinating in the field of unloading right now is just this focus on heart failure. Despite all of our advances in drug and device therapy, we're still seeing in 2021 that there's an increase in mortality due to heart failure in the United States. And these are the typical colorized charts of the US map where you can see that change. And I think this harkens, this need for more understanding of the biology of heart failure, especially in the contemporary era. Now, this is a really nice review from Doug Mann, speaking of standing on the shoulder of giants who've come before us. This came out in Circ Research 2021. And I would encourage everybody to take a look at this review because it does another really beautiful job of integrating the molecular aspects of cardiac remodeling, both adaptive and maladaptive remodeling, and correlating these things to symptoms as well as time and ejection fraction. And so with that initial event, which could be an acute myocardial infarction, it could be myocarditis, it could be other etiologies, this idea of looking at damage to the myocardium, how the heart responds with compensatory mechanisms, and whether or not this change from initial event to those dilated cardiomyopathic hearts and then going back is really the question. Can we go back? Can we reverse remodel in this era? And what I really like about the review is that it starts to get a much more integrated look at the role of the kidney, the different signaling mechanisms inside the heart, and then the peripheral vasculature with this VA coupling concept that we've talked about in different forums. I think one of the things that we've also really started to emphasize is in this era of coronary revascularization and this question about the utility of elective PCI, this is really not elective in patients with heart failure. If we have a patient who comes in with acute myocardial infarction with or without cardiogenic shock, revascularization is a critical part of recovering that native myocardium. But even in the patients with heart failure, who have early or late heart failure, where they've started to develop some thinning of the myocardium as well as developing potentially some dilatation, that's a critical role for revascularization. We've seen that in the surgical literature, and now we're beginning to also see that in the percutaneous coronary intervention literature. And then this final group of end stage, I think it's important for folks to recognize that there are different stages of this remodeling process. And it's in that final stage that maybe revascularization may not make sense. And that's where some of the longer term unloading strategies, cardiac replacement strategies may have a role. But I think this is a really important concept, is that it's not just about unloading, it's got to also be this reversing of the underlying problem, which in many cases can be ischemia. And when we start to think about this from a metabolic perspective, I think it's important to recognize this is where the basic science really starts to accelerate. So under normal conditions, our cardiac myocytes are consuming fatty acid through fatty acid oxidation. This is a highly efficient way of producing ATP through the citric acid cycle in our normal hearts. When we undergo injury, acute MI, we start to see that there's a shift from fatty acid oxidation to glycolysis, a very inefficient method. It's a high energy consuming approach to try to generate energy. And so that inefficiency really starts to accelerate myocardial damage and reduce the likelihood of recovery. And this is seen also in the hibernating myocardium. And then certainly by the time you get to LV scar, you're really seeing really minimal to no metabolism at that point. The other key factor from the past is that it's important to recognize that adverse cardiac remodeling certainly in the acute as well as in the post-injury setting, is load dependent. And this is the classic slide from Marv Konstam and Jim Udelson back in 2010, illustrating that if you can start to change load conditions, here they're doing it with a drug, enalapril, you can start to see that there's beneficial effects on ventricular size and ventricular remodeling. And in the bottom right panel, panel C, you can see that Dr. Udelson did a really great job of illustrating that when you look at the various trials and you look at the odds ratios that are favorable in blue, below the line of unity at 1, are the ones where you're starting to see a reduction in volume, in an end-systolic volume in this particular case. So the load dependence concept that's been around for decades has also set the stage for unloading now as a therapy for reversing this adverse cardiac remodeling substrate. So the ultimate question for all of us here at ACURE and all of the folks who are interested in unloading is, can we harness this ability to unload the ventricle and use this as a therapeutic approach, not so much as an enabler of adjunct procedures, but actually is the unloading itself a therapy? And so in the dilated cardiomyopathy group, this is again another phenomenal review from Doug Mann talking about the plasticity of the heart, where in the dilated hearts there may not be that plasticity. And if there is, it may require a combination of unloading as well as other therapies to go along with unloading. But in the acute MI setting, this is really where there's a golden opportunity to get that unloading done. And that's why the talks that you just saw from some phenomenal postdocs from labs around the world are really targeting this reversible damage where it's still in that acute MI setting. And when we talk about standing on the shoulders of giants, this goes all the way back to the 1800s with Frank Starling, Wiggers, Guyton, and then now in the more contemporary era, Suga, Sunagawa, Dave Cass, and then we're honored to have Dan Burkhoff here as well. I always put his picture there as well, and he's really changed this idea of understanding ventricular load. But now all these postdocs are now, and the ACURE faculty are going to become the pioneers of our understanding of ventricular unloading. And that's what we anticipate for the next few decades. And the fundamental science that you're hearing about, this talk about pressure volume area, the correlation with myocardial oxygen consumption, in the upper right panel as well as in the bottom right panel, you can see that there's a lot of component of this oxygen consumption that's related to mechanical work. But calcium cycling and metabolism, I think, are really the areas where you're going to see more growth in the unloading science field, and especially around calcium cycling. As was mentioned earlier, this was the Nobel Prize looking at this mechanosensitive component of calcium handling. And we are now in the era where mechanical unloading may be directly affecting those mechanisms. And I don't think it's lost that we're starting to look at Nobel Prize winning science and putting it in the context of unloading. And I think that's going to change the trajectory for the field and for cardiovascular medicine. So the advent of durable LVADs in 2007 really changed the field. It changed everyone's perception. As you can see, this is one of the old HeartMate pumps, and the pressure volume area reduction with durable LVADs, really started to change people's understanding about this concept of reducing PVA as a therapeutic approach to recover hearts. And so as a result, this unloading field has now opened a spectrum of opportunities to intervene, ranging from the acute MI patient, the heart failure patient, high-risk PCI, the decompensated heart failure patient, as well as the advanced end-stage heart failure patient, all of whom are substrates for investigation by ACURE faculty and beyond to look at the effect of unloading. Now, there have been some really phenomenal reviews. This one was put out by Nir and Dan, looking at whether or not LVADs alone can promote myocardial recovery. It's not a 2-hour lecture, so I'm going to leave this slide for reference for folks to look at. But when you look at the data, you're going to see all those fundamental mechanisms, looking at genomics, proteomics, and metabolomics, looking specifically at LVADs, and can they actually achieve myocardial recovery. And one of the really interesting papers came from Nikos Diakos, who came out of Stavros Drakos' lab looking at metabolism. And what they illustrated in this report, which I thought was very exciting, was that LVADs can increase glycolysis. We talked about that change of fatty acid oxidation to glycolysis. But interestingly, when you're unloaded, there seems to be this uncoupling of glycolysis and glucose oxidation. And as a result, there's still this sort of alternate use of fuel substrates like amino acid metabolism. And so this is a really important one to read, I think, for anyone in the unloading sphere, because it suggests that unloading has a direct impact on cardiac metabolism, but there may be a difference between durable unloading versus acute unloading. And so for all the investigators out there, I think this is a great area to start to penetrate into. Now, for acute MI and unloading, I think it's really important to always recognize the 1971 publication, the sort of the sentinel publication from Morocco and Brunwald. And in this paper, this was the first paper to suggest perhaps that it's not just about opening a blocked artery, but maybe it's about regulating myocardial metabolism, myocardial oxygen consumption, and using a pharmacologic approach like propranolol back in the 1970s was sufficient to reduce infarct size back then. And so, of course, this is what's really created the substrate for our current understanding of load versus unload. And when we refer to ventricular load, we refer to any variable that can increase myocardial oxygen consumption. So you're starting to hear more data come out about regulating heart rate, regulating wall stress, regulating workload mechanically. These are all now the concepts and targets of therapy where we can look at unloading. And when we look more specifically at reperfusion injury, I think this is sort of the most proximate area where we think we can get myocardial recovery and durable effects on reducing the likelihood of developing heart failure. It's important to recognize that most cardioprotective approaches have focused on reducing reperfusion injury once you open the blocked artery. But now, as you're beginning to hear from these postdocs that just presented, there's now some interesting data talking about reducing just ischemic burden itself. Before you even reperfuse, you can change the trajectory of that patient's likelihood of developing heart damage. And so this concept that time is muscle is extremely important, but it's also important to recognize that unloading may now create a window in that time trajectory where you can now do other things to intervene. And I think that's one of the most exciting aspects is uncoupling ischemic versus reperfusion injury in the unloading space. And I think we're all now pretty familiar with the pressure volume area reduction with transvalvular unloading and how this translates into physiology and also translates into reduced myocardial oxygen consumption. But in preparing for this talk today, I always go back and I think we really should always take a look at the original Bart Main's paper from 2003. Every time I read this paper, I always find something new. And actually, I use Bart's publication to help create the trajectory and the roadmap for the next series of grants coming out. And in this paper, I think it's important to recognize that Bart and his colleagues identified that one of the mechanisms of observed myocardial salvage is related to myocardial perfusion. And you're hearing a lot of science and talk about coronary blood flow, the collateral circulation, but also the metabolic needs are reduced. And in this paper on the left, Dr. Main shows very effectively that this reduction in myocardial oxygen consumption during the ischemic period also shows benefit in terms of reducing infarct size. And on the right, he now looks at it in ischemia reperfusion injury. So this was one of the first studies that started to uncouple ischemia from reperfusion and look at the impact of changing myocardial oxygen consumption. And so you can go back over 20 years to find these data and start to look at what's coming in the next 20 years. And this was also soon followed a couple years later by Richard Smalling and Wampler, who started to look more specifically at coronary blood flow. This was using another transvalvular assist pump. And what they identified was that timing is critical. When do you initiate mechanical assistance? And so, as you heard also from the postdocs this morning, a lot of the discussion is about the timing and the sequence and the duration of unloading. And this was also, again, coming from almost 20 years ago, where we learned that if you can unload before reperfusion, you can change coronary blood flow, reduce myocardial ischemia, and then potentially open the blocked artery and lead to better myocardial recovery. And this is then followed on by work by Dr. Ishikawa, who is here with us this morning, where he started to look more specifically at coronary blood flow, but looking at it post-infarct in the period where after an injury has occurred, can continued Impella unloading change coronary flow dynamics, and showed very elegantly through various microsphere studies that there is enhanced coronary blood flow even in the post-infarct period. And so that's the idea now, is to start looking at this effect of coronary blood flow coupled with ventricular dynamics. And you're going to see more data coming out over the next few decades on that as well. And then we also partnered in our laboratory looking again at this idea of collateral circulation. We went back to a very old index called the Collateral Flow Index, and Natalia Burcheno from the UK, as well as Devaka Pereira and other postdocs who joined in the lab, basically were able to show that there's an important timing period where when you start to unload with an impella, there's an increase in collateral flow, and that collateral flow recruitment continues to increase over 30 minutes of unloading before you reperfuse. So it seemed to be that that 30 minutes was really critical for achieving that maximal reduction in area at risk, optimizing collateral flow before you open up a blocked artery. Now, when we start to look at the downstream effects, we've gone from the ventricular physiology to the coronary physiology, now looking at the myocardial signaling effects. It's really important to recognize that many, many drugs have been attempted to harness these salvage kinase pathways. All the different pathways ranging from calcineurin to trying to basically look at cyclosporin, all the different things that might target mitochondrial protection as well as augmenting different pathways that are in the reperfusion injury salvage kinase pathway. And one of our earliest papers, I think that really got a lot of people very excited, this was in Circulation 2013, was using the tandem heart transvalvular pump using a left atrial unloading source to basically show that we could reduce infarct size by unloading, but not only just unloading and opening the artery, but waiting 30 minutes. And this, I think, is really important because it started to couple hemodynamics with direct myocardial effects in terms of infarct size, and then looking at those salvage kinase pathways. One of the first studies to show this link between unloading and myocardial biology, and also introducing the idea of delayed coronary reperfusion. And this was then followed on by our lab with 60 minutes of unloading before reperfusion with the Impella device. And this study really put the burden of proof on Impella because we increased the injury in the control arm, but also suggested that 60 minutes of loading with persistent LAD occlusion is required. And what you can see here is that we also showed again with transvalvular unloading a significant change in salvage kinase biology as well as myocardial oxygen consumption. But to take a really deep dive, we then followed this work on with a look at global changes by looking at a transcriptomics profile. And what we realized in this study was that LV unloading has implications across thousands of genes and thousands of signaling pathways. So I think this really sets the stage for the next 20 to 50 years of science, starting to look at each of these different gene pathways and what is the impact of changing myocardial mechanics. And so this idea of translational mechanobiology, I think, is where we're going to see even more excitement come out. And of course, in this paper, we also illustrated this timing element that was brought up by Richard Smalling and Bart Maines, showing that not only do you need to do unload before reperfusion, but actually that delay element is what's critical in terms of getting that collateral circulation recruited and the myocardial biology altered enough. And in this study, we also started to introduce this idea that there may be changes at the mitochondrial level. And so this has really gotten us very excited because all those gene changes we were seeing all pointed towards myocardial metabolism and mitochondrial protection. And this also extended out to 30 days of a reduction in scar size. But those mitochondrial images that came out from this paper, I think, are also going to now set the stage for even more work looking at specifically mitoprotective biology with unloading. And this also has implications for ECMO as well. So this idea of mitochondrial integrity is really important for folks to be aware of. There's a lot of excitement about doing mitochondrial transplant to try to recover hearts. We're also learning that ECMO has a significant impact on mitochondrial biology that's really never been identified before. And now can we start to target these dysfunctional mitochondria? Because without the mitochondria, the likelihood of myocardial recovery is significantly diminished. And so this then led to the 2020 report that came out from our group, starting to point at this link between unloading, cardiac metabolism, and mitochondrial protection. And then this observation in here, if you look at this paper, which really highlights this uncoupling by VA ECMO, that even if VA ECMO can reduce pressure volume area or reduce stroke work, there's still this myocardial damage effect that almost seems to be independent of the hemodynamic component of VA ECMO. And that, I think, will open up another area of exciting science to now look at the biology of ECMO. And when we started to look in a metabolomics profile, what we saw on the right is all of these changes in metabolomics that start to point again at mitochondrial function and now start to introduce this idea of calcium handling. And I think that's where, again, we start to look at those novel findings as a roadmap for future studies with mechanical unloading. And as you heard from Lesia earlier this morning, there's a really exciting biology around hypoxia-inducible factor. She really nicely went over the fact that HIF-1 can be used as a biomarker of ischemia, so as a sensor for oxygen or lack of oxygen. But also, we're now beginning to question, is HIF-1 a target of therapy? So the fact that when she attenuated HIF-1 expression with the 2ME experiment, and she showed that that actually attenuated the protective effect of unloading, really starts to suggest two things. One is that unloading itself may be changing ischemic substrate before reperfusion, but also suggesting that maybe there's a change in the myocardial biology as it relates to HIF that could also be targeted. And so this was the illustration she showed where there's a nice reduction in infarct size correlating with increases in HIF expression. But this is really the paradox that I think that Lesia's gotten us very excited about. What you're seeing here is this transition from ischemia to reperfusion. And when you look at the red bar, which is with no pump involved, as soon as you reperfuse, reoxygenation leads to a reduction in HIF levels. There's no more hypoxia. And so as a result, HIF is getting degraded and the red line starts to come down during that reperfusion phase. But what's really interesting in the blue line is that in the unloaded state, there's this persistent elevation of HIF, and in fact, it starts to go to supraphysiologic levels. And why are we seeing that unloading, even after in the setting of reperfusion, is driving up HIF biology? And it's important to recognize that HIF is a double-edged sword. In the pre-ischemic phase, it has one function, but in the post-reperfusion phase, HIF is actually cardioprotective. So if you could actually augment HIF expression and do it perhaps during that window of unloading, could you now start to maximize infarct reduction by combining device with drug? And that's where some of the exciting work that's coming out from Lesia's work is going to point to this new target of combining drug and device strategies. And I think one of the other, as I mentioned earlier, one of the other exciting areas is around calcium handling. It's important to recognize that calcium cycling is a mechanosensitive event. I'm quoting Bart Griffith, who published this study back in 2013, where he used the Impella 5.0 device in a post-infarct model, tracked these animals out for days, and looked at scar. But importantly, in this study, with some really pioneering work, he started to show that there's changing in calcium handling that occurs even days or weeks after a period of unloading. And you can see various targets of calcium handling like SERCA, NCX, and also phospholamban. And some of those are some of the most key elements of calcium cycling, and you need to have those intact for myocardial recovery. So one of the really exciting areas that the lab is now beginning to dive into is this link between beta-adrenergic signaling as well as calcium handling. And some of our early data that we aren't going to be showing in too much detail today suggests that Impella unloading has the ability to regulate phosphorylation of phospholamban at different sites, the threonine site and the serine site. And this has important implications, again, for stabilizing calcium cycling and then leading to subsequent myocardial recovery. And what we're going to do is start to look at this in the ischemic period without reperfusion and in the post-reperfusion period to see whether or not that calcium handling can translate into single myocyte changes with force max generation if you're unloaded versus if you're not unloaded. Now, as you also saw from Kay, I think all of us in the ACURE field should be starting to point towards ECMO. This area of ECMO is really a black box. There hasn't been aggressive investigation into the impact of ECMO on right ventricular physiology, left ventricular physiology, systemic vascular biology, and also on the renal effects of ECMO. And Kay's work that she showed you today with these really nice pressure volume loops as well as the correlation of PVA is some of the first steps towards taking a deeper dive into ECMO. And her reperfusion injury pathways looking at salvage kinases is some of the first steps. But where you're going to see a lot more science come out on VA ECMO in the next few years, looking at this combination of ECMO, Impella, and other techniques to understand ECMO biology. So if we go back to mechanical unloading, going back to Doug Mann's roadmap that he's provided for us in 2021, I think for all the postdocs, all of the investigators out there, take a look at this slide and recognize that if you look at different clinical substrates, AMI, RV function, cardiogenic shock, dilated heart failure, and acutely decompensated heart failure, and then you start to look at the cardiac signaling, the kidney, and the cardiorenal interactions, and the vascular responses, we now have set the stage for the next 50 years of acure science coming out, all focused on the effect of mechanical unloading and its global impact on cardiac remodeling and heart failure. So I want to, of course, acknowledge ACURE. This has been one of the most exciting meetings for this group of physicians and scientists who are targeting acute cardiac unloading, going all the way back to our initial meetings in Barcelona, and then now to our virtual platform, which will hopefully be shedding the skin on this virtual platform in the coming months to years. But this group has really driven bedside to bench science and back again. So for all the investigators, start thinking about the clinical trials, the pilot studies, to really push us back towards the bedside based on all the biology that we're seeing today. And of course, I want to acknowledge my lab and the NIH for supporting our work with 3 R01s. And it's exciting to see all the R01s coming out from ACURE investigators based on the conversations we have every year at this meeting. And of course, I'm eternally grateful to my team of teams who help us get all this work done. So thanks very much for your attention.